Dr. Raj, you're on mute, I think.
Thanks, Madhi. Friends, I think this is the third time that we are talking, or at least second time. I can't remember. Very glad to have this opportunity to talk to you on the last day of this season. You know what the subject is. So even as an opening question, I hope you won't mind me asking this question to the 37 participants here. If you like, you can respond on the chat box. Are you able to think about your own death? Geeta, thank you. Harpit, kind of. Okay. I'm going to wait a while. So, friends, in about less than a minute, we have less than 1/3 of the audience giving a yes, including a sort of yes. Not easy and possibly rather cruel of me to ask this question to young people at the prime of life. Or possibly it's cruel, it's kind to be a bit cruel at this point of time. At some point of time, sooner the better, it's good to recognize that death is the inevitable consequence of life. That we will all die someday. That our loved ones will die someday. Why? I mean, like most people will tell you, we think of negatives, think positive, think of beautiful thoughts. Like the beautiful tree behind Mr. Dasi Prabhagar Rao. Absolutely lovely. Why do we have to look on the dark side? There are two reasons, friends. One, if we recognize that, we will value life more. Once we are able to accept that it is there, it can be tomorrow, it can be 80 years later, that's fine. But there is a limit. And during that time, we should do things which are most meaningful. I don't necessarily mean grandiose things. Meaningful things can be you and your boyfriend or girlfriend having a nice dinner together. It can be just having a holiday. It can be a good time. It can be doing something that will give pleasure to you because somebody else benefits from it, whatever that is. That's one thing. Secondly, eventually, it is not necessarily yours, but in your family, when you come across the end of a loved one, it would be good to find yourselves prepared. Because when we are not prepared, we do some terrible things. When the thought comes to you, I can't live without my mother. I can't live without my mother. And when that thought comes, you are likely to inflict all kinds of horrendous suffering on your mother because of your selfish love. A selfless love would be thinking, my mother must be suffering so much. Let me do the best for her. Let me do the best for her. The best may mean chemotherapy, but may mean deciding no more chemotherapy. The best may mean even when she is so sick, because she wants to, traveling 100 kilometers to see her brother who is in bed once more. Meaningful things done meaningfully. So friends, I took almost 10 minutes saying this. Death is the inevitable consequence of life. And once we are able to acknowledge it to ourselves, we are able to spend the remainder of our lives more meaningfully, not chasing useless things. And secondly, when it happens in your own family, you are able to deal with it rationally. And again, try to make that person's life as meaningful as possible. And finally, we are all healthcare providers, including the lawyer in the team and the managers and administrators. We are all healthcare providers. And once we accept our own mortality, we are able to help people with serious illness better. Instead of going to the sickbed of some dying person and say, think beautiful thoughts. It's okay to say it only because the person is too weak to give you a slap. It's a horrible thing to say. Instead, once you recognize one's mortality, you are able to empathize more, think from that person's point of view, and do the best for that person. 10 minutes, friends. Do you already have a comment on what I said? Or a question? No smiles there. I mean, everybody is looking grim. Naturally, I'm talking about horrendous things. How can you smile? Lakshmi, I see a forced smile on your face. You made it happen. Lakshmi Vadapalli. Is there anything on the chat box, Senior? If questions appear on chat box, please respond. Surya says certain aspects of death she is able to think about. Or she or he, I'm sorry. Okay, if there are important comments on the chat box, I may not see it when I am showing us my presentation. So please point it out, Senior.
Sure, sir.
Shall I share my screen?
Yes,
And proceed with this discussion on end of life, starting by saying that I am not quite sure what end of life is. So when does it start, the end of life? Maybe it starts with birth. It is still defined in numerous ways. In a system in USA where insurance companies decide what is life and what is death, they have decided 6 months. But definition is not important. But before I proceed, let me bring you back to these things that you must have talked about in your session on communication, in your session on grief, right, Smriti? This must have come up at some point of time.
Yes.
The 5 reactions. So when we try to help this person who has an incurable, maybe a terminal illness, maybe a relative, maybe your patient, you will remember that this person could be at any of these stages. Important thing to remember. This is not only for communicating bad news. Wherever the person is, we have to travel with that person. We cannot drag everyone by force to acceptance. We can only walk in that direction, gently guiding the person if the person is willing to travel in that route. That's the first point I want to say. Find out where the person is. Meet the person where he or she is. At this point, that emotional exploration becomes vitally important. Sometimes you will have to wait. You will have to wait for the right opportunity. And even when a conversation has started, there may be periods of silence. We will have to learn to respect that. I earlier asked you a question. The last point, these are things that I said. When the time comes, if we are to die as well as possible, we have to start preparing now. And as care providers, we have to, I'll bring you back to this thing that we must have mentioned on the first day. Our duty of care is to mitigate suffering, primarily to mitigate suffering before anything else. Of course, cure sometimes and relief often and comfort always. But there exists no exception to this rule that our primary duty is to mitigate suffering. Our primary duty is not to prolong life at all costs. It is not to stretch out the dying process by a few more days, which means a few more days of suffering in that case. Unfortunately, we live in a country where suffering at the end of life is universal. As my friend Dr. Sankhamitra said, the poor die in misery of neglect. We see how they die. Most of you wouldn't have seen how people die. I myself did not see how our poor die in my own villages till I started doing palliative home visits. The middle class die in misery of ignorance, and the rich die in misery on ventilators. Sankhamitra says, no one in India gets a pain-free and dignified death. Of course, everything has exceptions. And between the two, with me, most of you will prefer this kind of ending. Maybe very humble, but a few drops of water, not a suction catheter as the last thing to go into me. Unfortunately, why Sankhamitra says can be visible in this image. Let me take you through the first. This is a 2019 publication on European practices. You will all have a senior will send you this slide deck so that you will have the reference also for anyone to go deeper into it if interested. What this shows is in Western Europe, 90% of people on artificial life support systems in the intensive care unit are taken off the system. They are instead given palliative care. In Western Europe, it's one of the richest parts in the world, where they can afford to do anything. This is what they do. The 10% is quite understandable. You cannot always predict death. You think this person has a good chance to cure and continue the interventions. That's understandable. But they take away 90% of life support systems and give palliative care. Whereas in India, only 30% of people are taken off life support systems. This is when treatment is considered futile. Even when treatment is considered futile, even when you call the family and say things are very bad, looks like he can't make it, you still continue the life support here in our country. In 70% of cases. And in the 30% cases where we take them off, in the vast majority, we do it brutally and cruelly. You know how it happens. Most of you would know. The non-medical people in the team may not know it. Let me tell you what usually happens. For the vast majority, 96% of people in India, no palliative care is available. So for somebody with major respiratory failure, if you just stop the artificial ventilator, they will be in serious respiratory distress. So what do? We first make the family sign horrible documents saying, I am I am taking my mother away from the hospital against medical advice. The medical advice is to continue inappropriate treatment. Against medical advice, I accept all responsibility for my father's death or my mother's death. How will a son or daughter feel when they have to sign that thing? And something that frequently happens is the person is connected to an ambu bag, a device that squeezes air into the lungs, put in an ambulance, the nurse will accompany up to the ambulance, and the wife or the husband or the daughter or son is told, squeeze it 12 times a minute and allow the person to die in the ambulance or at home with that person who squeezes feeling that I must have made some mistake because of me. My mom is dead. These are horror stories from science fiction that's happening all around us. I don't think I am painting too bleak a picture. This is the reality, which we all together must change. Smriti, this is something that we discussed a while back, maybe a couple of months back. This is called a palliative performance scale. How do you know that one person is close to death? And how do you know how long the person may have? There is no way of being sure. This is not absolute. This carries at least 75, okay, there is maybe 25% chance that we may be mistaken in our evaluation, but this is a scale. I'm not going to details of it. If somebody is interested, please study the slide deck when I send it to you. I said I'm not going to the details of it because we just wouldn't have the time. And maybe it's not all that important. But what you do with the scale is you start here, ambulation. So where is the person? Let me stop the share for a minute and tell you the story. The story of my mornings for the last 9 days. I usually take a walk in the morning. For the last 9 days, my walk leads me to a house that is about 2 kilometers away, where a classmate of mine is living with terminal advanced metastatic cancer. It's not as if we were great friends or anything. Our batch had 186 students, and we were most of the time acquaintances. We were not close, ever. But now we are close. This man is a clinician, head of an institution, a medical college. This is confidentiality in the group. I'm not going to tell the name or identifier, but still, if you guess the person, keep it to yourself. He was very breathless when I saw him. On the third day, he announced that tomorrow I am going to my college. The family, the wife, and one of their 2 sons was there, looked absolutely sad to hear this. They felt sure that he would die on the way. But he went. His college is about 70 kilometers away. He went by car with oxygen. And it's not for just 1 hour. He spent practically the whole day there. In the afternoon, by about 3 o'clock, his work was done. Whatever he wanted finished. And he came back. He was okay. He continued to be okay for 2 or 3 days more. And then started deteriorating. Goba Mukherjee just now sat your chat. We will talk about it later. From that day, the remaining 6 days, he became progressively weak. Very headstrong person, never ever obeyed anybody in his family ever. He was very much always in command of the world around him. The world included his family, grandchildren, and the college, all the students, all the staff. That was his world. He had no world apart from his place of work and family, except for a little bit of time in his place of worship. Did somebody say something? No.
Sir.
He is breathless. Now he is very breathless. Continues to lie only on one side. He cannot even turn back and lie on his side. Rather than my slides, now I thought I will tell you the story about when I met the first day. I wanted to start him on morphine. He declined. He said, I'll go after I have gone to my college on Monday. I said, this tiny dose is not going to make you drowsy. It may actually help you to breathe better. He declined. Then he came back and started a tiny dose of morphine. Actually, he is now on 2.5 milligrams morphine 4 times a day. Actually, he had significant pain on his shoulder, which is now gone. And he's breathing a bit better if he is lying on one side. He has to eat on that side. We have an airbed under him. I hope his skin doesn't break because he cannot even lie on his back. So this morning, when I saw him, I sat beside him. What do you think my first question was? Nothing. I just went and sat by him and waited. After a few seconds, remember those silences. They can be very meaningful when people are confused, people are trying to organize their thoughts. He said, I want to get out of these toxic medicines. So I asked him what he meant. He meant morphine. I explained to him again that he was in delirium at one point of time, not any longer, possibly because we treated his constipation, but possibly also because he is not in pain. Pain is something that causes delirium. There may be many reasons. And I pointed out that morphine is not a toxic material. It is something that is physiologically present in your brain. Endogenous opioids are normally present. And sometimes what nature provides is not enough. You need a little more to cope. He grunted. I am not sure that he believed it, but he is continuing to take it. Then he said, lots of questions. Lots of questions. Not many answers. I waited. I didn't say anything. He said, I have lived a good life. I waited. He didn't say anything. And then I said, very few people at this time of one's life is able to say that. What was I doing? I was validating his feeling, acknowledging his success. And that started him off. He talked about how 3 days back he got news that almost impossible has been achieved. His college admissions for MBBS has been increased from 100 to 150. He was breathless, but this was what he was rejoicing about. And he said, the chairman came himself. The chairman, Dr. Chandrasekharan, can you remain muted for a while? Dr. Chandrasekharan, please stay muted for a while you are having your conversation. So he said the chairman himself came. I was visiting him every day, but I did not know this. He stayed here for 1 hour. Why? He was asking me. He was challenging me. Why? And I asked him, why? That's because of my integrity. That's because I considered work more important than anything else. I am not sure that I agree with his philosophy. But that was not the time to point out anything. That was the time to listen and validate his philosophy, his theory of life. And he went on speaking, this breathless man went on speaking about the various things that he achieved for his college. And he said, I have wrapped everything up. I went last Monday and wrapped everything up. Now things can go on. To himself, he was validating the value of his life. Friends, you all have been exposed to very well to the domains of care, total care, physical, social, emotional, spiritual. In the 45 minutes that I spent with him, with the kind of conversation that I described, what aspects was I dealing with? Physical, emotional, social, spiritual. You can unmute and answer or reply on the chat box. Physical, emotional, social, or spiritual. Shridhar, his physical pain was treated successfully about a week back. He is no longer in physical pain. Dr. Mohammed, the emotional, Sakshi, spiritual. Gola, spiritual. Sudhi, spiritual. Mohammed, if you say emotional, that's fine. It is emotional, no doubts. But I also suspect that is a bit deeper than that. With Sakshi, Gola, Shruti, Lakshmi, and Geeta, I would say specifically at this point of time, I was addressing his spiritual well-being. He was addressing it. He is lying there on the left lateral position forever for the last 4 days, eating in that position, getting an enema in that position every 3rd day. And he is asking himself, what has been the meaning of my life? And by validating that, not challenging it, by showing my respect to him for this, I was giving him spiritual support, I believe. as a way of spiritual support, I did not have to invoke God. I know for a fact that my relationship with God is this far. He is very close. He could lecture me for an hour on faith or religion. I can't. But nevertheless, by acknowledging the value of his life and also respecting his wish to stay at home, his wife she's also a doctor, a professor of a medical professor, desperately wanted him to be brought to our inpatient facility because she was scared to handle a catastrophe at home, what she saw as a catastrophe. But we all respected his wish. And he can, senior, can you admit Dr. Chandrasekharan, who seems to be waiting in the room, a waiting room?
Sir.
Thank you. Why am I recounting that story? Not only because it is fresh in my mind from a few hours back, but also because we have to remember this. Once we have taken care of the physical suffering, other things come to the surface. Friends, did I do the introductory session for you? The first session?
No, sir.
No, okay. Senior, was Smriti's that video clip from a TEDx talk shown to this group?
No.
Okay.
We can search
Okay.
for it.
No, that's okay. I don't think we'll insert it without planning and create a problem, but it would have been nice for them to see it. Between social, emotional, or spiritual, the distinction may not be very clear. Whatever is important comes to surface only when you have taken care of the physical problems, at least to some extent. Intense pain or intense breathlessness, all symptoms occupy the person's mind completely, leaving no space for any other human emotions. But when you have taken care of that spiritual pain, physical pain, these things surface. In the story that Smriti was, I mentioned the video of Smriti was recounting the story of a person with advanced malignancy who was in physical pain. And when asked, what is the thing that bothers you most? Smriti says, the man remained silent for 6 minutes. People waited. And then he said, all that I wanted in life was my children not to be fishermen like me, but to have a good future. And the support for him thereafter came in the form of an offer of a document offering educational support for the children, which transformed the remainder of his three remaining days of his life. So, after physical suffering, for anything else, you look for it. Allow the person to talk, allow the person to share. And when they bring out what is most valuable in their lives, acknowledge them. And when I told my friend that very few people have the ability to say at the end of life, like, my day was good, let night come. My kitchen is clean, the fields are plowed, and everything is in its place. That's not something that everybody can say, but he could. But friends, my story about him doesn't stop there. Later, before I left, I came to the living room. His wife came with me, and we sat and talked for 10 minutes more. She talked about the difficult life that she has had. He was a very determined person with great determination, great personality, and maybe, in her words, an autocrat. She had no life of her own. It was only his shadow. And especially the elder child had a very tough childhood because of his domineering dad. She said all that and said, The only thing that I am praying for is that he should not suffer anymore. That was my end of life care for my friends. It included the physical evaluation. It included also gradually, with the permission of other treating doctors, abandoning the idea of further chemotherapy, stopping needless medicines, including the cholesterol medication, but mostly listening, acknowledging, and validating. In the case of my friend, his wife wanted his wife and children. Children had plans to make. One is in another country, another is in another city in India, and they had come home. How long could they stay? One has left his family back home, his own family. They have important works to do. We sat and talked. So this is how one assessment of palliative performance is made. Again, I'm not going to the details, but in his case, is he ambulant? You start from here. You don't start from here. You start from here. Not ambulance. Mainly in bed. No, not really mainly. Totally bedbound. This is where he is. Then I move right. Unable to do any activity. Extensive disease. Extensive disease. All three are correct. Total care. He is not able to do any of his daily activities. So he is still somewhere in this lane. And here, intake, normal or reduced, minimal to steps, so mouth care only. He had an idli today. It is reduced, but it's normal. It is certainly not sips. He's here. And here, consciousness, full or drowsy with confusion, or always confused. He is somewhere here. He is somewhere here because sometimes at night he is delirious. Early morning he is confused. He is not always as coherent as when he was with me. So because his appetite is here, food intake is here, this is where I place him. That means palliative performance scale 30%. I repeat, this is not absolute. But when I have done this, that helps me to prognosticate. If palliative performance scale is about 30%, in people with cancer, the average life expectancy is about 13 days. It is likely to be as low as 7 or as high as a whole month. Unfortunately for him, he is looking forward to leaving early. If he was unable to eat, I would have eat or drink, I would have placed him here. If he was unconscious also. If he was conscious but still unable to drink, I would have placed him here. Now, please remember, this is only a broad guideline. There is 25% chance that it may fail. At least 20% chance that it may go wrong. Not absolute, but helps us in planning for his life. People are not the modern generation, because we are not used to joint families. We are not used to seeing that. We don't know. Doctors themselves haven't had. I know that there are some doctors there. I bet that they had no training in end-of-life care, though that's such an important part of medical practice. We all passed MBBS with no training. And then we got our MDs or MS or whatever with no training on this. We also don't know how to prognosticate. So Because we did this 3 days back, yesterday, she brought her sister and husband across and sent the children back, both of them, to the important professions that they had to leave. I'll repeat, this is not absolute, subject to error. Before I move on, would there be any question? Or comments? I know that the vast majority, at 3/4 of the audience, were not prepared to think about your own death. So let me talk about my own death. When I am in the last month of my life, what would be important for me? You have to know that because you have to help me to achieve that. If you take it as your duty only to treat my disease, I have nothing to say to you. Maybe you are not going to be of great use to me. In fact, you may be harmful for me. You may be a problem, not a solution. But if you accept the duty duty of care to relieve suffering, then you think about what would be important for me in the last month of my life. After treating my physical symptoms, listen to my story without judging. Sometimes these stories have never been told to anyone at all. Stories that are deepest in oneself come out to you. It's a huge privilege, friends. It is such a huge privilege. You have you have the access to a door which has never been opened to anyone else, including the spouse, including the children. Not necessarily because it's secret. There was no occasion to say it. Some seemingly inconsequential things of my childhood. Why should I keep saying that to my wife or children? But now those things are becoming important to me. Validate the feelings, just as I told the person, though I don't agree with his philosophy of life. That's my personal problem. I'm not a judge. I validated it by saying very few people would have the opportunity to say that I have lived a good life. Many people may express regrets, guilt. It's not necessary to say, no, you don't have to feel any regrets. Don't say that, just validate that. And if there is something you can do about it, do it. If not, don't say meaningless things. Sit back and listen. Acknowledge all the positives that you hear in the story. This can be not necessarily to the patient, but to your own family, your mom, your dad. If you sit down and say, Mom, tell me about your childhood, then you will hear stories that you have never ever heard, possibly stories that nobody has heard. On such an occasion, my grandmother told me the horror story of her aunt as a young single woman burning herself to death. And the story took half an hour. It was there. From all the stories, acknowledge their positives and respect silences and be there when you can. There are occasions, usually in your workplace, if you are just sitting down and relaxing, your boss is likely to come and say, don't just sit there, do something. This is a situation where you say, don't just do something, just sit there. What would be important for me would be these things. Geeta, Hagit, Sakshi. If I am lucky enough to have one of you as my caregiver, I hope you will not be able to touch me. You will not be afraid to touch me, to hold a hand, because I may be wishing for a hand to hold at one point of time, because deep inside, I am scared and I have no one to say it to. If I say I am scared, my loved ones may say, don't be scared, we are here for you. But instead, just hold my hand. And how many intensive care units do you know where this is permitted? A child allowed in? That may be a fight worth fighting for. These are the important things in one's life once you have made the person physically comfortable. Not everybody is like my friend whom I met this morning. Not everybody, not to everybody is worship. Most people value human relations more than anything else. So friends, when we provide objective end-of-life care, we want to make the person as comfortable as possible, physically, emotionally, socially, and spiritually. And when we provide that, when we do not provide that, when people die in pain, in emotional or social suffering, disconnected from their world, living a life in the last few days of no meaning at all, receiving no love, nothing important to them, then the family is left with memories of suffering, memories of guilt, and memories of broken relationships. Instead, if at that time you provide them tender, loving palliative care, we achieve physical comfort, we rebuild connections, like a brother who has been quarreling with me for the last 3 years, coming and shaking hands, and finally hugging each other and crying. Make the remaining time meaningful, even if it's a day. Allow me to leave a legacy. Suppose I say I want to write my will. A loving family may say, don't think about that now, concentrate on getting better. No, this is important to me. And I want to leave warm memories behind. And the family will then be able to live with warm memories. Very important. They will value relationships, the relationships that they have had with the dying one. And they will the dead one, and the satisfaction that they have been able to help. Even if at that time it was very difficult to get away from work, take leave and stay with them, later on, that will be a satisfaction. And whenever person seems to be unconscious, make an assumption that he or she is able to hear. What's the harm? What do we lose? Just keep talking. And attend to the family also. Just as I talked to his wife today and to the sons 3 days back. See where they are emotionally. And if anybody wants to facilitate religious rites, like a last communion, a final prayer, always facilitate that. It can be very important, even within the intensive care unit. I hope no one dies in the intensive care unit. Unfortunately, that's far from the reality. Parthasarathi Shom was former financial advisor to the Prime Minister of India, and he writes about his mother's death. Even on the day of passing, a specialist recommended a liver function procedure. When asked if it would end the coma, the answer was negative. But the doctor said, we have to keep on doing everything. That's a misunderstanding. That doctor has not been taught end-of-life care. You don't have to keep on checking the chemistry in the last few days. or in the last few hours. And we have to think, you keep poking the dying person with another blood sample. Are these things necessary? When the person is finding it difficult to swallow like that, we just force multivitamin tablets and atorvastatin into them. And you can't get a vein, so we want to poke her nose in and do a central venous cannulation. But good heavens, why? What are you trying to achieve? And especially when you find children as caregivers, dear friends, give them special attention. This is one of the hardest things that we see. Children forced to behave like adults, take all responsibilities, and they lose their childhood. But also they get scars in their psyche. I'll skip that. But this is a recommendation out of 10 low value or harmful practices that should be avoided in cancer care, created by the National Cancer Grid, a collaborative of all cancer organizations in the country. And they say, do not treat patients with advanced metastatic cancer in the ICU unless there is an acutely reversible event. And friends, when your own family face this, please remember this. You have a right to protest. You have a right to argue for the person and keep the person out of ICU if they do not have a curable illness anymore. And please remember, withdrawing artificial life support, stopping the ventilator in futility of treatment is not euthanasia. Euthanasia is mercy killing. That's killing. Withdrawing artificial life support is only allowing natural death. Passive euthanasia is a misnomer. Euthanasia is killing. Passive cannot be, no euthanasia can be passive. I am not saying this. This comes from the bioethics unit of the statutory body of India government, that is Indian Council of Medical Research. To those 9 people who raised their hands who are able to think about it, let me tell you, please prepare advanced directives. At no time, or if you are an adult, at no stage are you too young to do that. And please remember, friends, I have written it. If one of you is caring for me, please remember, the doctors who treat me have the ethical and legal duty to respect my wishes. The Supreme Court of India in the judgment last month has put in some month before last, has put in some impractical procedures like there's no law in our country for this. This 2023 judgment is improvement on the 2018, but still they use the term passive euthanasia. And they have still an impractical procedure. One board after the other will have to meet and declare that treatment is futile. It's time consuming, unfortunately. So what do? We should not escalate the problem to the legal issue if at all possible. If we know what the person wants, if I have made it very clear to my family and they have agreed, then the legal questions do not arise. The physician hopefully will try to mitigate my suffering and not to stretch out my dying process. So please create the advanced document. I have given a sample here. You will have the presentation. Take the link, open it. You will find the document. Sorry for the typo. Gazetted officer or notary public will have to countersign it and keep it with all the records that medical records we have. Make sure that you go take it to the hospital. But most importantly, always have agreement within the family. The document itself will be of little use if your family is protesting. A recent Lancet Commission report of 2022 came out with these recommendations. 2021. The management of suffering should sit alongside extension of life as a goal of health services. And all of us need to remember that. That education on death, dying, and end of life care should be in the curriculum of every health and social care student. I know that the majority of audience are medical social workers, and all of us, social workers, doctors, nurses, pharmacists, everybody should learn about dying, end of life care. And patients and families should be provided clear information about the uncertainties as well as the potential benefits, risks, and harms of interventions in potentially life-limiting illness to enable more informed decisions. These are some of the recommendations. Unfortunately, these are the barriers to cross. The doctor believing that they have a duty to keep the heart beating at all costs, which is a misconception, but developed by the medical system in the last quarter of a century, only in the last quarter of a century. That's the main problem. The family's selfish love, wishing the person to be life to be stressed out, the social fears, and then the legal issues are the barriers to this. So we need to think about it. We need to talk about it among friends, among family, and with media partners. There should be a concerted efforts. Smriti, we need a concerted efforts. We need a plan. This group is very precious. This group, just by the faces that I see, register sincerity and concern. We should exploit that and create some literacy about death and dying also for the future. I see that we have half an hour left. That was deliberately done so that we have enough time for discussion. Smriti, friends, before the session, when Smriti said she is coming in for the session, I tried to discourage her. Smriti, how long is it that since you lost your mother?
23 days.
I wouldn't have recommended somebody who has had such a recent loss to join this session. So I told that to Smriti, and I said this is the third session that she is attending after her mother's death. So some people, by thinking about it, discussing it, and facing it over a period of time, may get to accept the inevitable, which doesn't make the grief any less. Well, maybe it does. Maybe at least one aspect, the loss of grief of loss is still there. But that will be there forever. We just grow around it. Before opening up for questions, I'll also mention that Goba Mukherjee, about 45 minutes back, wrote this on the chat box. A delicate and sensitive topic indeed. I remember I kept on asking my mom, is there pain? Would you like to take a soup, a bit of water? I feel so guilty now. She was focusing on her death now. Gopa, I'm sorry that I raked those painful wounds out and made you suffer as we were having all this discussion. If you would like to speak about, if it is too hurtful for you to speak, you don't have to. But if not, please feel free to unmute and speak. Gopa also has now written, I used to light a candle each evening for my mom. Prayed chants. And
yes,
Gopa,
yes, I 6 months passed. I have not been able to come out of the trauma. I do all my regular work, throughout the day, but in the evening, those days only I kept for my mom. Throughout the evening, throughout the day even, but daytime I still have been able to cooperate myself with my regular work. I run a organization. I work with the autism kids, autism ADHD kids. So there is there is always work and work pressure, counseling in the daytime. But till now, even after 6 months, I have not been able to take any case in the evening time. Even after 4 o'clock, I feel that I have to rush back home. I have to look after my mom. I do not know. I have not been able to cope. My coping is still on. And those days, when I never knew, never understood about palliative care. And in Kolkata, there were, not that support at that time, even not now. I got the support very late. From Eastern India Palliative Care. Uh, However, they had helped me over phone time to time always. But initial stage, I had nobody to, who could guide me. So those days, I did everything single-handedly for my mother. I never ever wanted that she could be looked after by anybody else. And I honored each and every wish of her. Like, she never wanted to go to hospital. I said, okay, fine, I will arrange everything at home. Then whenever she had wanted anything, wanted in the sense, at those days, she wanted to be quiet. She had some, psychological layers, I must say, that she was she was an early aged widow, and she did everything on her own throughout her life. And her concern was that she was not able to do something for the family. She could cook well, but she could not cook for people at that time. And she was sharing, she used to share, different spiritual, uh, talk with, me, with everybody. And she had been so practical at last, but it was me who used to, disturb her. And I understood it quite later, that she wanted to focus on her date. She wanted to keep quiet. She wanted to, not to talk much, but I wanted to talk with her. So it was like that.
Gopa,
But
I'm
I must
sure.
say, I have opened a small palliative care unit near my office, and I have started, to work also, just on the memory of my mother. And I'm really thankful to Pallium India that, I have been able to learn something from the sessions, so that I will be able to, support more people.
Friends, I have a suggestion to everybody here. Whoever is at home this evening at 7 o'clock, let us light a candle with Goba. She lights a candle for her mother every day. So at 7 o'clock this evening, whoever can, the others may not see it, cannot see it. That's okay. Let us light a candle for Goba's mom. I am going to. Goba, you have this urge to get back to home, to your mother every evening, though your mother is not there. Do a lot of people tell you, hey, stop this, get back to life, stop thinking about your mother, she's gone. Do you get that kind of advice often? Goba?
Yes, yes. People try to suggest me always that, yeah, those are gone. Wherever she's well. Now you have to move on. Those are the part of life. However, I mean, we had such a strong bond. I lost my father at the age of 9, and at that, since then, she was my mother and my father. So whatever a sanskar we call it, that I have developed within me, it was because of her. And I'm fortunate that she had blessed me. Wholeheartedly. We used to, I got time with her. We used to talk on a lot of topic, and we used to share at last, like the way you told that, uh, the childhood stories. There were a lot of stories, lot of experiences, and all the good experiences, spiritual talk, and songs, chants. She had shared a lot, and I'm fortunate enough that I had seen those days even. On her last days. We have got time. Otherwise, I couldn't manage much time. To talk about that, but those days we talked, and I still feel people, and I still have not been able to come out of the trauma, and I do not want to talk about it to people who always try to be so practical that, yeah, now it is your life, you can move on, there is nothing to look back, there's that. But this is hard to believe, but somehow, because somehow I feel that no, the soul is there around, and the soul is taking care of me, and I'm also thinking of the soul. Somehow I still feel I'm so connected.
Thank you. Thank you, Gopa, for sharing that. It must have been very painful to share all this. Isha Bistar, in response to your story, the question, when people tell you, hey, get off it. Get back to life. You can't go and sit and cry all your life, etc. I think about that. Isha says this would be very insensitive. I agree, Isha. It is insensitive, but it's also out of ignorance. They are talking about common sense. And common sense doesn't necessarily cater to what experience can bring. They don't know. And so Gopa has to brace against that kind of things that will continue to happen. All of us will have to at some point of time. They will say, we must learn to just ignore them or smile and say thank you and move on. But I want to share one more image with you.
Doctor, can I share one opinion?
Oh, just give me 1 second. Let me complete this, what I was about to say. You see an image on the screen?
Yes, sir.
See the top panel, 3 bottles. The people who advise you, hey, stop worrying, get back to life, think that with time, grief reduces. It does not. Ask Mudi, ask everybody who has gone through it. It continues to be the same. Only thing is, we grow around it. And as we grow, accepting the loss, gaining from all the happiness that you have had together, you grow to an individual where though the grief will always be there, the loss is always there, you learn to live with it because you have grown. Sorry, I interrupted somebody. Who spoke?
Dr. Chandrasekhar.
Dr. Chandrasekhar?
Doctor, I think I heard my name before itself. Once you...
Dr. Chandrasekhar, somewhere
Yes,
after the first 10 minutes of the session, you were unmuted and having a conversation with somebody else, and your conversation was audible to everybody. So I was requesting you to mute at that time.
Okay.
Where are you, Dr. Chandrasekhar? Where are you speaking from? Where do you live?
In Bangalore.
Okay. Thank you, Mr. Chandrasekhar.
I'm a palliative care center, a 50-bed facility in Bangalore.
What's the name?
Tema Hospital Palliative Care.
Smriti, will you please make a note of that? Our senior, I never knew about such an institution.
We have the details with our team, sir.
Okay, very good. Friends, we have only 16 minutes left. Most people have not spoken. More questions or comments? Isha wanted to say something. Isha?
I want to ask, how do we support children who are caregivers?
Very difficult situation, but very essential. Children, sometimes there are no options. The teenager or the 10-year-old is there taking care of the whole family sometimes. There may not be many things that we can actually do to help to shift that role to somebody else. Sometimes we are able to, but everybody's then lays more and more responsibilities on that person. And they are too weak to say, I am exhausted. We, Isha, first and foremost, Isha was the one who asked the question, right? Isha, first and foremost, you and I will understand the burden that the child is on. The burden on those young shoulders. We will acknowledge this. You will give a hug and a kiss on the forehead. Acknowledging, valuing that child. You must acknowledge that they are doing an impossible task. Try to ease their suffering as much as they can. What can you do for them? Certainly, they are worried about the medicines. Will I forget something and somebody will come and scold them? Suppose we organize them into 3 small packets, everything to be given in the morning, afternoon, evening, something like that. Little things that we can do for them. And do not expect impossible burdens on them. And for heaven's sake, never inflict guilt on them. I came across this recently. 2 teenagers were living with their mother. The father was in a Gulf country working there. And at night, the mother had a heart attack, severe. They called their aunt, the mother's sister, who did not take the call in the middle of the night, of course. She was asleep. The girls called an ambulance and took the mother to the nearest hospital. For the next 2 days, the aunt went on scolding them for taking the mother to that hospital and not to the best hospital in the city. And they lived with such guilt. I am glad we had an opportunity to value them, commend them on their courage, and also to support them through a local volunteer.
Dr.
So,
Raj,
Haji.
sorry. No.
Bolo.
Once you're done, I just wanted to add.
Yeah, I am done.
Also, I think it's really important to, not the child already feels like they grow up too fast when they have to do something like that. But comments like, you are the head of the family now, you are the man of the house now. I think those things are best avoided because we have to remember that in their hearts, they are still children. They need to be given that space to be children for as long as possible and provide that safety for that.
A friend of Smriti's and mine, she is in Palim, India, who lost her father at the age of 9, says she was the younger child of 2, but she was a smart one. Because she was the smart one, every visitor who came after the father's death said, you must be the head of the family now. You must look after their mother. She says her childhood ended that day. She took that seriously. She no longer could play. She had to be responsible. That's a huge calamity. Thank you, Smriti, for pointing out that important thing.
Hello, sir.
Ravikantji?
Yes, sir. Namaste, and I am Ravikant, working as a consultant psychologist, Apollo Hospitals, Vishakhapatnam.
Hi,
Sir.
Dr. Ravi.
Hi, sir. So the thing is, if you can start some courses, something, because so far whatever we have learned here is the basic in the palliative care. But in case if you opt for any specific counseling skills in the palliative care and some advanced courses, because people like us are a bit eagerly waiting for such courses to learn more in depth of the palliative cares. So if you can organize such sessions, maybe or monthly basis or something, because I came to know that you visited in Vizag once, but yeah, DSI
Hello.
center.
Yes,
Yes, sir.
Doctor. Sorry. Whoever is speaking, please hold on. Dr. Ravi is speaking, and let us conclude that discussion, and then we can come on to you. Dr. Ravi, yes, Vaishak is a beautiful place, and I love that seaside walks. Senior, please make a note of that comment. I know that it can be valuable. I also know that our virtual education team is overloaded with work, but this is also frightfully important. Smriti, though I asked Senior to do it, that she can only do the follow-up. And because you are the psychologist in the team, maybe we'll have to consider it greatly. First, do we have the capacity to do it, intellectual capacity to do it? Maybe we can do it in collaboration with Elizabeth Kubler-Ross Foundation. I don't know. They may be willing to cooperate. And thank you, Dr. Ravi. We'll make a note of that and try to do our best. I totally recognize the value of this. Ordinary counseling courses do not give enough attention to grief counseling or to counseling in the palliative care context.
So we've actually,
because
sorry, Ravikant,
yeah,
just to let you know that I
please
have,
continue.
yeah, we've just put in, we're putting in the framework of a short-term but intensive program for specifically this. And so happy to also get in touch with you separately to draw your, needs and how we can structure a course in a way that is most useful to you practically on the ground rather than us telling you from our side. So I'll get in touch with you separately on that.
Thank
And
you.
also
Thank you.
to add a little more, because nowadays the psycho-oncology is playing a vital role in the entire gamut of these palliative care. Because hardly there are very few experts, sir, because you already know
Yes.
the facts and statistics. And if you can start building ecosystem for all of us, and that would be a great area.
Point not kiya jaye isme. But Dr. Ravi,
Yes.
totally accept that. At least psycho-oncology is evolving. We
Yes, sir.
only on psycho-oncology. I mean, like that's only 22% of all serious health-related suffering. 78% is from other diseases. Are we giving, causing a caste system and giving attention only to some diseases? Certainly, this aspect of care and palliative care and grief care is vitally important. Thank you, Dr. Ravi. Somebody else was
Thank
trying to
you.
say something. Sorry, who was it?
I just want to say that you can refer to Nimhan's website. There's a topic about presentation and material on grief and trauma in it for children. So it's under some workshop. Just go to Nimhan's website and try to find something. You'll find a lot of material.
Oh,
Thank you,
okay. Thank
Isha.
And
Thank you,
child and
Isha.
adults in psychiatry department.
Thank
I think it's on workshop or project or something like that. Just have a look.
Okay. Thank you, Isha. We have 7 minutes more. I think we have exhausted all questions.
I have one,
we-
for you, Dr. Raj.
Hanji.
I think you and I have navigated this conversation with several people, that we've been in touch with. And I was wondering if you could just share with sorry, that's my mother's dog at the back asking for a biscuit. I've already given her 20. Right here. So we've had these conversations about very often with children in their 30s or younger or even in their 40s, where the parent is already in the hospital on some sort of life support interventions, and they are, they want to have that conversation where they want to take them off life support. And it's a very difficult time. These are families that have not had the time to have those advanced care planning conversations. So they're already in that volatile state. So I was wondering if it would be helpful if you could talk to the group a little bit about, if someone were to find themselves in that spot where they know that maybe it's better to take them home, what is the kind of conversation they should be having with their healthcare providers?
Smriti, very, very difficult question you have given me. So a loving daughter, a friend's niece came to my home day before yesterday in the evening. Her father is in the intensive care unit, shut up, tied up, artificial life support, and she wants to rescue him. Fortunately, the ventilator could be switched off. He's breathing by himself. And but then that's all. She wants my help to rescue him from there because the doctors are saying, no, he can't be discharged. No, he needs dialysis. No, he will need to be seen by the cardiologist. I had this difficult task of telling her that now that he is no longer able to take decisions on his own, you are the person with the authority to take decisions. The hospital cannot refuse discharge. No, they are saying that we cannot discharge today. We'll think about it Tuesday. And I repeat, so and so, I am telling you that they cannot refuse. You have to insist. You have to be able to say that you are not asking a favor. This is your right. And we want to transfer him to a palliative care center. Discharge her. Give them 2 hours. And this, oh, no, I have known this doctor for the last 17 years. How can I go and tell him this? See how considerate she is. But sometimes we have to let the person on the street know that this is my life, just as Hajit, Sakshi, your life is yours. It belongs to you. And if you are no longer able to competent to take a decision for yourself, it's up to your family, next of kin, to take decisions. The medical system cannot prevent you from taking the person home. If they say, no, we cannot discharge him, we need 2 more investigations, you just need to say, no, I'm sorry, we are going. Now, at least in that kind of society, you always have a lawyer in any group. Even in this group, we have a lawyer. If necessary, take that help. Not to file a suit, that never gets you anywhere. But we have an activist lawyer working with us as a volunteer. And what she says is, waive the law in front of the people. That's all you need to do. You don't have to file a suit. Say, I insist. And then they will do it. They keep doing it. Some people have the courage to do it. But my friend's niece did not have. The man is continuing with inappropriate treatment. So we have a huge challenge there because the medical system has not studied it. A few handful of people know about the Supreme Court ruling, what is permitted and what is not. The doctors don't. They say it's against the law to discharge, would be against the law to discharge him from ICU. They say it would be against the law not to give him dialysis. And we have to insist. We have to educate the people. So in between, I use the term death literacy. Smriti, with all the... Oh, I'm so sorry for that explosion. Now we have the power of this group, several FCPC groups, the Arohan groups. Let us start a revolution. get death familiar to people. Death is an enemy to be feared at all costs. Let us talk about death. That death is a part of life, inevitable part of life, the end of life. About talking about it, knowing about it, facing it when the time comes. Smriti, we still have a minute left, but if you have a specific question regarding that navigation, bring it up as the last point, and then we'll close the session.
No, Dr. Raj, I don't.
I know that is a very tough question, which sometimes doctors and hospitals think we are their enemies because we talk in these lines. But I also am sure that Smriti and I and Senior and all of you have the duty to talk about it, because an injustice is being done to dying people if they have money in the pocket. Paradoxically, the poor people die much better in our country than the rich. They die with some water going down their throat. But that kind of thing is their right, and we have to talk about it and shout about it from the rooftops. Okay, ladies and gentlemen, thank you for that. Many of you participated actively in the discussion, and that enriched the discussion. Smriti, thank you for being here. Oh, Senior, back to you and your colleague to close the session.
Smriti ma'am, do you have anything to?
So we started the session, this series for non-medical practitioners, and over the many last few batches, we found that doctors and non-doctors and non-medical people alike have wanted to be a part of it. I'd just like to say that our relationship should not end here. And as Dr. Raj indicated, there are several other things that we're working on. There is a deadline.
May I have a last word, please?
Yes, Dr. Chandrasekharan, I'll just finish
Oh,
what I was.
yeah, Dr. Chandrasekhar, please. Please
Yes.
give me 2 minutes.
Oh, okay, go ahead, please.
I just had one question. I am still treating, the end of life care, but what about parents and entire family? How do we counsel them? They just don't understand. They always talk about money. He has to sign. I'm in Bangalore.
Dr.
You know, when-
Chandrasekhar, Dr.
When
Chandrasekhar,
it
you have
comes
brought.
to inheritance, the child is dying. Nobody realizes that. That's
So-
a very this thing,
Dr.
We
Chandrasekhar,
don't
certainly you
understand.
have a very important point brought up.
Yeah. When it comes to inheritance, what we do?
Smriti, would you agree with me that this is too big a question to be taken up at this time of the evening? Dr. Chandrasekhar, please send your question by email or something, and we'll talk about it. I wish we had brought this point up when we had the time, but we really have to close the session. Smriti, will you continue with your comments?
Yeah,
Dr. Chandrasekhar, my apologies that we don't have the time now to go into the details, but I would like to very much to take it up with you or an email conversation or WhatsApp conversation. Senior, will you facilitate that? Dr. Chandrasekhar has an important point to mention.
Yes, we'll do that. Yes, sorry. So I was saying that we have a death literacy campaign underway with the Arohan group. I'll be happy to share with you. We've started a once a month webinar series. And last month we did a very important one on estate planning and will planning. And I invite all of you to please join us to be part of that campaign, whichever part of the country you're in. Senior, if you can just let Senior know in that WhatsApp group, I'm also part of that WhatsApp group. And if you put your hands up, then we'll just include you in the larger campaign strategy. That's one thing. The other is Sina will also be in touch with you about potentially a bonus session, 2 bonus sessions that we will be doing with this group. One is on advanced care planning, which I think is an absolutely essential topic. And the other is Sina will talk to you about the case presentations. But thank you very much for being part of this entire series. Thank you for such active participation and enriching our sessions with your stories and your shares, and also for those vulnerable stories that you put down here in this group with us. So see you next time. It's been a pleasure to interact with this group. Senior, over to you.
It has been a long journey, few weeks with us. I'm requesting all who are interested, please message me, please message in my WhatsApp so that I can add you in the Arohan WhatsApp group. And all the other details will be shared in your WhatsApp group. It's already late. Thank you, Dr. Rajagopal, for being here with us. And thank you, Smriti ma'am, for facilitating today with us. Thank you so much. Thank you all for joining. Bye-bye.
Thank you. Thank you very much.